On the Go podcast.
Today we meet the allograft expert, Dr. Adam Yanke, Associate Professor at Orthopedic Surgery at Rush University Medical Center and Sports Medicine Orthopedic Surgeon at Midwest Orthopedics at Rush. He serves as co-director of the Cartilage Restoration Center and vice chair of research within the department. Join us for a coffee break with him and Dr. Jari Dahmen, Amsterdam Medical Center's University of Amsterdam. My name is Takao Shima, and this is On the Go, the podcast all around orthoregeneration.
Happy to be here again. Today we welcome Dr. Adam Yanke, Associate Professor of Orthopedic Surgery at Rush University Medical Center and a Sports Medicine Orthopedic Surgeon at Midwest Orthopedic at Rush. And you serve as a co-director of Cartilage Restoration Center, and you're the vice chair of research within your department. And welcome to our podcast.
Thanks for having me.
Great. As you might have listened to our previous On the Go podcast, we always begin our podcast by asking you how do you drink your coffee? How often? How much? Where?
Always, all the time, and as much as I can get. But it's typically espresso, extra shot with a little bit of milk.
Amazing. And now it is 1:30 p.m. here European time, but your time is 6:35, so it's an early morning start for you, I think, right?
Yeah, a little early. No coffee yet, but I'm feeling good.
Perfect. That will come after. And so you're just starting up your day. Just take us a little bit through how your day looks like, and what a typical day for you looks like.
Yeah, my week is split between surgery and clinic. So 3 days in the office, 2 days in the operating room. Today's an office day. So be heading out to clinic after this. And then tomorrow's OR. And then Tuesday was OR too. So just a little bit of mix of both. Spend some time doing research also. That's usually on the fringes and when I can.
Yeah, so do you do the research in between the cases to just take a little look at the manuscript here and there, or how do you fit that in your schedule?
Yeah, I have a team of people, so it's extremely helpful. They're working all the time, and so then we check in, as you mentioned, between cases, sometimes between patients during the office. We'll hear updates on studies, some early results, try to formulate, next directions. And then between working with our research assistants, our residents, fellows, and medical students, there's really a team of people that's working on it all the time, which allows me to do the clinical work most of the time, but still have a lot of fun with the research side.
Amazing. It sounds like a very good combination, a very good way of being effective on a daily basis. Linked to that, I was able to read that you also hold a PhD in biochemistry. That's something that's especially special in the United States, I think, combining an MD and also a PhD. Could you tell us a little bit on how that path went?
Yeah, pretty atypical. I had a mentor in Ohio where I grew up and went to school originally before medical school. I said I wanted to move to a bigger city. I lived in a smaller town in Ohio, and I was looking to go to New York, Chicago, or Boston. And he sent me to Chicago. He said, you should work with this individual who at the time I didn't know at all, who was Susan Shubinskaya. And next thing you know, I'm a technician in her lab. Then I'm getting into medical school at Rush. I stay on there, continue to do work with Susan. She becomes my master's thesis advisor. Then I started working with Dr. Brian Cole, did a year of research with him, finished the master's, and then matched in residency. And then thought there was enough work that could be done, and Dr. Shubinskaya agreed that we could expand the master's into a PhD. So declined that degree, continued the work on the PhD throughout my medical school and residency. and then stayed on for fellowship. So I finished it during those 2 dedicated years, plus the time I was spending throughout training. And so then that's kind of how that came to fruition. But I had always had an interest in a PhD, even applying to medical school, and liked science. And science was actually what got me into medicine originally. And then became interested in surgery and the rest of it. So not a typical route.
No, exactly. It's something special to hear, especially from maybe the colleagues also around you. And is that that training that you had as part of your PhD, how is that currently helping you with your daily clinical and research work?
Yeah, it's come full circle for sure. So when I started in practice, I was very focused on building a clinical busy practice, having it look like what I would like, which is cartilage restoration, patellar instability. So the focus was that early on. And then as time went on, I found that I had more time to dedicate to clinical trials, wet lab work, and biochemistry work. And through the last 2 years, through a few different changes, Dr. Shubinskaya took a leadership position outside of our university. And then I ended up taking over the lab that I trained in. So now I run our lab. And now the amount of work that we do in there for me has increased significantly because my engagement has gone up significantly. So I would say I'm now entering an even heavier research zone, which I enjoy a lot. And I think it's a good phase, good time of my career to be able to take some time to focus on that now that my practice is more mature.
Yeah, amazing. And talking about your practice, I think most people know you as the go-to cartilage surgeon around the world. But could you maybe tell us a little bit more about how your practice looks like, what kind of practice you run, and how much of that is focused on cartilage?
Yeah, sometimes funny to hear, I guess, that I do 40% shoulder. So I think some people maybe aren't aware, but 60% knee, 40% shoulder. In the shoulder, it's anything from rotator cuffs, instability, shoulder replacements. And then within the knee, everything except knee replacements, other than patellofemoral arthroplasty, and pretty heavy focus on the cartilage and patellar instability side. So on any given year, I tend to do more MPFLs than I do ACL reconstructions, which has definitely been a change in my practice compared to 5 years ago, even. And then cartilage transplants and osteotomies, obviously I love and have a fairly high volume with. So that's been a focus as well. A lot of those, as we were talking about, are osteochondral allografts, but I try to stay engaged in really all technologies. And Tuesday we did osteochondral allograft, a MACI, and Misha implants. So it's a wide range from helping things outside of the knee to inside the knee, reconstruction, cell-based. So I still try to stay engaged in all of it.
Yeah, so you're still doing a broad perspective and broad variety of cartilage procedures. What's your current treatment algorithm, especially maybe if we focus on the on outside of the patella, so more the femoral condyles? How do you approach the patient with a cartilage lesion from your expert point of view?
Yeah, for the condyle, first of all, for any defect, we a lot of times still start with debridement. Condyle doesn't have as favorable response as the patellofemoral joint to debridement as far as causing symptomatic improvement. I still think that our data on improving the natural history of cartilage wear with cartilage transplants is fairly lacking. And so if you have a smaller defect where somebody can improve with injections, chondroplasty, really start with that in the vast majority of patients because our success rate is just not high enough with cartilage transplants with minimal recovery. That will be the secret sauce is as we get to faster, easier recoveries, more reliable improvement, then I think aggressiveness of surgical indications might increase. But the half of people will benefit from a debridement alone. So that is usually where I start. If we do a debridement and it's not beneficial, or we're in a situation where someone has an ACL tear, they have a root tear, we're going to put them on a restricted recovery anyhow, and they have a smaller defect that seems to be symptomatic. That is the rare situation where I would perform marrow stimulation. So that still does play a role to some extent, but it's very rare that we do that. And then, finally, osteochondral allografts are the workhorse for sure. So once they've been through all of that stuff, that usually is my go-to on the femoral condyle. I feel like the results are very reliable in that location, and sometimes they need associated meniscus transplants or osteotomies. So there's obviously some more nuance there, but I'd say that's like the general idea.
Yeah. And yeah, you mentioned already the allograft transplantation a couple times. And I think reading through PubMed, that has been your signature procedure. Could you tell us a little bit more about how why that procedure is reliable in your sense, and why the graft variability and viability matters so much?
Yeah, it's interesting, that I think there's some things that are less obvious from even the literature that are beneficial about osteochondral allografts. So first of all, you go back to theory and the biochemistry of it. That there's no technology to date that generates hyaline cartilage. So the only thing that has articular hyaline cartilage was your knee at the beginning and osteochondral allografts. And that doesn't mean that allograft can always maintain that cartilage. That's the other piece of the puzzle. But at least it's starting with that. So, it's a big hill to climb to say that we're going to grow cartilage that's as good as what your body did throughout all of skeletal immaturity in 6 to 12 months. Also, in an unhealthy environment where the synovial fluid cytokines are really unfavorable to start. And then the variability of treating the knee like a petri dish, where we have to grow something in the knee, you can get, it has to be basically like a tumor, like a controlled growth is what you want, or you really don't want it to be a tumor, which would be uncontrolled growth. And so overgrowth, doing debridements for cell-based procedures because they've gone beyond the cartilage surface, things like that. I just ran into less issues in that category with osteochondral allografts because they basically either integrate or they don't. And so they're a little bit more of a binary outcome. There certainly can be some things on the fringes that can happen with them that are more of a gray area. But as long as the surface doesn't delaminate or come off, you don't get large cysts form, then you've had structural success. And that doesn't mean that you have clinical success, but I don't want to have to worry about too many categories. And there's enough other things that cause pain in cartilage patients that if the graft looks questionable, regardless of the one that I use, and they still have pain, then I'll always be blaming the graft potentially, when it might even be the synovium or the cytokines or other issues that are causing pain. So that's why I've tended to migrate to that. I also think that patients get a smoother joint initially, which sounds a little basic, but the idea there is that crepitation and any mechanical symptoms that could occur from catching on the edges of the defect should also be gone day 0 with an osteochondral allograft, because it immediately creates a smooth surface across the joint.
Mm-hmm. And I think what is especially interesting, what you mentioned with regards to the cyst formation after the surgery, coming from the ankle, where my interests mostly lie. This is something that we see quite often. How often do you see it after allograft procedure in the knee, and what is your go-to skill to prevent cyst formation happening?
Yeah, it's a great question. And it's almost 50% of people will have some type of cyst. So whether it's large or small. We did a randomized clinical trial looking at the utilization of bone marrow aspirate concentrate and applying it to osteochondral allografts, and found that you had less large cyst formation. So it didn't decrease cyst formation overall. You actually had slightly more increased likelihood of small cysts that would form with bone marrow aspirate concentrate, but less large cysts. And the large cysts were more likely associated with reoperation or continued pain. And so currently trying to treat the biology of the bone on the back of the graft has been the focus. There's been some studies that Andreas Kamal did that showed that if you make too little bone, your failure rates can be higher because you just don't have enough structural integrity, probably, maybe a little bit more micromotion, because you just don't want synovial fluid coming in that interface and propagating those cysts. So I do think that there's some technique components there of like a nice tight press fit is important. But biologically, we currently use high pressure CO2 to try to blast out all existing marrow elements. Then pulsatile lavage, similar idea. You can actually alternate those back and forth to help clean it out more fully, and then apply bone marrow aspirate concentrate. And to date, that's the only one that's been evaluated with an RCT for incorporation, and it's the only one that showed benefit. So the other studies that exist have mixed results between PRP and bone marrow aspirate concentrate, but they also had different forms of evaluation. Weren't level 1 studies, utilized X-ray for some studies, MRI versus CT, so there's a little more variability there also.
Okay, very interesting. And you mentioned the CO2 and pulse lavage. Could you tell us a little bit more about that? How you perform that in the OR and what the outcomes are?
Yeah, we've looked at this. Another group, and Seth Sherman's looked at it as well. But essentially, when you look at the back of the graft, you can really see the marrow elements still interdigitating within the cancellous bone. And that's the component that we believe to be immunogenic or have a component that the body will view as foreign. And Bill Bugbee and Bob Saw and some others have done research on that. And so the idea is just to get it out of there. And right now, we don't really have a chemical way to remove it. And so we have physical ways. And so it's using this high pressure saline where you're basically blasting the back of the graft, trying to get that out or replace it with fluid. And then you use the CO2 to remove the liquid, because if you try to add bone marrow aspirate concentrate to saline, it's like oil and vinegar. They don't mix. And so it'll just bubble up on top of the graft. But as soon as you blast any remaining liquid out with the CO2, it just absorbs like a sponge, the bone marrow aspirate concentrate. And that's the work that Seth did, was showing that you increase the overall amount of BMAC that the graft can uptake using CO2 prior to application. Okay.
And I think that also brings us a little bit to the future, the future of maybe allografting or at least transplantation procedures in the knee. 2 questions. Maybe the first one is, when you see those cysts after the surgery, how often are these actually giving symptoms? And does this relate to the size of the cyst? And for the future, so the second question, more like a 20-year vision, is what do we need regarding research and clinically wise in order to prevent these from happening and to even become better in the operating room and for the patients?
Yeah, it's a great question. So the first one, it seems like small cysts are pretty irrelevant. And so if you have some small cysts less than 3 millimeters, clinically reoperation rates are still low. Pain symptoms are similar to patients without a cyst. When you have larger cysts, usually patients will also see a pain change. They'll have a honeymoon period. They'll say, I was doing well for a while, now I have a new pain. It's more of like a achy sensation that's there all the time. And it actually can be the pressure phenomenon from the cyst. And so for those patients, a lot of times we just drill into the cyst, unroof that area, which could even remove part of like 20% of the graft, leaving a small hole in that area, but just opening it up. And it actually usually helps their symptoms quite a bit. And so small cysts I don't worry about. I do get CT and MRI at 6 months and 12 months on everybody to kind of track that and see how things are progressing. But that's been my approach for the cyst part. As far as the future, I'll make a comment on your question before that I didn't get to address about viability and what's the relevance of viability, because I think it's part of the future of osteochondral allografts also. Osteochondral allografts, when they're first harvested, have theoretically 100% viability. And over time, we know that viability goes down with storage. And there has been some link of viability to success of the transplants. even though that data is not as robust as I think we would all like, but some does exist. And so anything that can improve viability is helpful, and that can be cryopreservation. So there's some new techniques where you cryopreserve the graft on day 0, which then you can rethaw the graft a year or 2 later. And so far, that company's data has demonstrated that the viability 1 to 2 years after freezing, when you thaw, it's higher than a graft that you take that's fresh, that's just been stored in media at 4 degrees C for 20 days, for instance. And so techniques like that, I think, are going to be extremely important. On top of starting with a good graft, we don't want to kill the graft when we put it in. And so we've looked at impaction before at our lab, but what we've looked at a lot more recently in 3 different papers is thermal injury due to the reaming of the graft and during the harvest. And so while we've been able to show that submersion in cold saline can mitigate any thermal effects of viability decrease during harvest, the part that we don't really have figured out is that you're still making a recipient hole with a large drill that is causing potential thermal damage in the surrounding currently healthy cartilage. And one of the things we see on second look scopes with osteochondral allografts is not necessarily the graft having problems, but the edges of the tissue adjacent to the graft starting to delaminate. And it's unclear if that's from damage from when we're trying to put in the new graft, or if that's progression of disease around that area. And so we've been working on quantitative MRI and trying to look at cartilage health with T1 row sequences throughout the knee prior to transplant, but then post-transplant, to see if our transplants are actually causing that damage or if that was already there on a microscopic level before we did the treatment. So I think there's still some room for improvement in that regard. And I think the big one is the environment. So we're doing some studies now looking at aspiration of patients' knees before and after transplantation to see what the environment is after transplant. We already described the different cadence of inflammatory factors that happen and cytokines and matrix metalloproteinases and VEGF. And so there's a whole different cycle of inflammation and cartilage degradation that can happen due to that. And so I think, aspirating patients post-op, removing any hemarthrosis that exists, being more proactive with injections into the joint of biologics as we figure out the best ones or the best mix, to give that thing the healthiest environment possible. Because imagine doing a cell culture in the lab and doing all the cultures of your cells under whole blood. You would never do that. We can't even get a good result with optimized media, let alone if you just expose it to blood, which is chondrotoxic. So, but in the operating room, that's what we do. We do a relatively large surgery, and then 30% of those patients have the hemarthrosis. So that's a major interest to me, and I think something that will ultimately be helpful to improve outcomes.
Well, that I think already answers a lot of questions with regards to the future question, the 20-year vision. So I think a lot to do and a lot to still look forward to. We're almost approaching the end of our exciting podcast, but not before we finish off with some more personal questions. What is your guilty pleasure?
Like synthesizers. Sounds like something that I would never say out loud, but in the last 5 to 10 years, I play in a band and I play keyboard, and so I enjoy music. And lately I've gotten into pinball, which is also a little bit random.
Yeah.
But I would say those are my 2 current guilty pleasures.
Nice. And maybe a bit more of a serious one. If you could give an advice or a tip to younger colleagues or younger researchers or clinicians starting out their career, what will be your golden tip?
Yeah, what everybody says is true. Things move fast, and I think that you need to have if you have something that you view as important at the beginning, it will probably still be important to you 10 years later. And it's very easy to lose track of that goal and be pulled in all kinds of different directions. And if you don't have like a guiding light of something that you view as important to your core and to what makes you happy, then it's easy to lose track of that. And so what I used to do was, I still do it, is I put above my computer like what 5-year goal I'm shooting for next. And in the beginning, it was getting into medical school and then getting into residency and all of those steps. But then it starts to become like what changes I'd like to see in the field. How do I think I can produce that? And so if you're interested in research and that's something that drives you, which it was for me, you just can't lose track of it because the clinical side will get so busy that it can just take over. And if you don't make time for it, it won't happen. So I'd say don't forget about the goals that bring you into the field that you love, and make sure you prioritize time to make them happen.
Well, thanks. I'm gonna print out my goals, put them above my computer or above my bed. No, great tip,
Yeah.
and thanks so much for being on our ONtheGO podcast. We really enjoyed it, and we hope to see the next 20 years all your amazing publications coming out. Thanks a lot
for having me. Thanks for taking the time too.
Of course.
This was ONtheGO, the podcast on orthoregeneration. For more content, stay tuned at my.on-foundation.org. Thanks for listening and have a great day.